Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Key HIV Studies Influencing My Practice Following AIDS 2022, featuring Dr. Chloe Orkin. Dr. Orkin is a professor of HIV at Queen Mary, University of London, and a consultant physician and lead for HIV research at Barts Health NHS Trust at the Royal London Hospital in London, United Kingdom. In this episode, she will discuss data presented at the conference, including on prevention strategies, oral and long-acting therapies for treatment, cure, and COVID-19 in people with HIV. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Orkin has to say about new data from AIDS 2022.
Thank you so much. It's really great to be here. I am dialing in from Canada, a very beautiful part of Canada, and I've seen Wales today, so I'm in a very good mood. I'm going to start with prevention. And the first study I'm going to cover was a really hot topic at the conference, and it was doxycycline post-exposure prophylaxis for STI prevention among MSM and TGW with HIV or receiving PrEP. And what happened is that either MSM and TGW living with HIV or without HIV were given doxycycline 200 milligrams of PEP, or the alternative was no PEP. So essentially what happened is they had quarterly STI testing for gonorrhea, chlamydia, and syphilis at 0, 3, 6, and 9 and 12 months post-intervention. And if we look at their baseline characteristics, what you can see, it was a predominantly young cohort, around 38, predominantly white, and predominantly 96% were gender-assigned men, and only 4% were transgender women or diverse. And you can see that STIs were pretty frequent over the past couple of months, and there was a median of 9 partners. So we're looking at a group of people who were at risk. And if we look at the doxycycline PEP primary endpoint, if we look at the STI incidence per quarter, firstly for the PrEP cohort, secondly for the PWH cohort, what you see is compared to standard of care, there's a very significant reduction in STIs. So really, really significant reduction. And you can see that this is the case, regardless of whether people had HIV or not. And you can see that this was regardless of infection. Now, you can see that chlamydia and syphilis were significantly reduced. Gonorrhea was reduced by around 55%. And this is different from the French study when gonorrhea wasn't reduced as much, but there are reasons for that. So we can see like around a 60% reduction in STIs, all STIs, with very significant reductions in chlamydia and syphilis and lesser reductions in gonorrhea. When we look at safety, adherence, and tetracycline resistance, we can see that there were no grade 3 AEs, no significant lab abnormalities or serious adverse events with doxycycline. Discontinuation rate was 1.5%. And based on self-reported adherence, 87% of sexual acts was covered by doxycycline. And we had tetracycline resistance data available for 30% of gonorrhea endpoints. And if we look at the tetracycline resistance cases, what we see here is that they were pretty similar to prior to baseline, so not very, very different. So all in all, a very good outcome. We do need more data on resistance, but the initial look it's not looking alarming by any means. It's looking quite reassuring, but amazing responses in terms of doxycycline PEP. So the next study I'm going to move on to is 6-monthly PrEP dispensing, and this is with HIV self-testing. This is a study done in Kenya. It was adult men and women in serious court and couples, and also single women using PrEP for a month. And what normally happens is they have to go in every 3 months, and they have to be tested. So what this study did was it left the standard of care arm as 3 monthly PrEP plus clinic visits. And then the investigational arms were 6 monthly PrEP, plus visits. And then basically they were given 6 months of PrEP and told to come back in 6 months instead of 3 months. And then at home, they could either do an oral fluid HIV self-test or a blood-based HIV self-test. So that was basically what happened. And there was a combined analysis for the 6-monthly PrEP. And it is quite difficult for people, particularly for financial reasons, to keep attending the hospital. So what we see here in terms of outcomes is that there was self-testing option with 6-monthly PrEP was non-inferior to the standard of care in terms of those who tested positive for HIV, for those that refilled the PrEP, and in terms of adherence. So that's really, really good news. But interestingly, the outcomes in single women, there was actually a superiority in terms of adherence to PrEP. So single women found it much easier to adhere to PrEP in this scenario. So it remained non-inferior, but it was superior in terms of adherence. So what we learn here is, as ever, different modalities make a big difference to different people. It's different strokes for different folks. And for some people, the idea of going in really was a problem. And this, made a huge difference. So that takes us to the next study, which is a preference study, looking at methods and socio-demographic characteristics of surveyed women in Namibia. And there was a discrete choice analysis of an anonymous survey of 1,675 DREAMS participants. And what was collected was demographics and PrEP knowledge, attitudes, and practices. And what you see from the cohort is predominantly people were single with less than secondary education. And there was some experience of PrEP. So in the 15 to 19-year-olds, only about a quarter had experienced PrEP, whereas in the 20 to 24-year-olds, almost 50% had experienced PrEP. So what did they think about PrEP? So in terms of this preference study, if we look on the left, there was firstly a question around preferred method of PrEP. And 83% were willing to use any option. So that's quite telling. But 61% would have preferred an injectable if they had the choice, 27% oral and 12% vaginal ring. And then when asked what were the defining attributes that affected this preference, it was quite a miscellany of answers. But if we start on the orange on the top left, discreet to parents was important, discreet to sexual partners, less important. Infrequent dosing was important. No or minimal adverse events was important. But the most important thing was that it works. So I think that that's an important consideration. But you can see that for these young women, discretion is a very important driver for the use of long-acting PrEP. So the next study I'm going to talk about is the outcomes for transgender women in the HBTN-083 trial, comparing long-acting cabotegravir versus daily oral FDC-TDF as PrEP in transgender women and MSM. So I think we all know about this trial. It was long-acting cabotegravir 2 monthly versus FDC and TDF. And we know that previously it reported 25 incident infections with cabotegravir and 72 with FDC and TDF. But this analysis is looking at safety, efficacy, and the gender-affirming hormone therapy interaction in the 570 out of more than 4,500 people in the study who were transgender women. And we're looking at the blinded phase. So what you can see is that in terms of the baseline characteristics, things were pretty similar across the groups. And there were no significant adverse events, very similar rates of STIs and similar rates of HIV acquisition. But if we look very importantly at the gender-affirming hormone therapy, what we see in terms of overall use, in terms of the PK on the right, is that you can see that there is no significant effect on the PK of long-acting cabotegravir. Now, interestingly, what you do see in the study is that relatively small proportions of people actually were on gender-affirming hormone therapies at the start, but quite a few people did actually initiate them on the treatment. And that tells us a lot about how difficult it is for transgender women to access hormones. So in terms of HPTN 084, this is the study for women. And what happened in this study is that long-acting injectable cabotegravir versus daily oral FTC TDF for HIV prevention in cisgender women. What we saw previously in the blinded phase was an 89% lower risk of HIV infection with long-acting cabotegravir. So with the current analysis, what we're looking at is HIV infections, cumulative HIV incidence, pregnancy incidence, and safety in the 12 months following the unblinding. So what we see here, 1 year from the unblinding point, is 6 infections on cabotegravir versus 56 with FTC TDF. And it doesn't take a genius to understand that this is superior. And interestingly, the hazard ratio has remained identical, so it's still at an 89% reduced risk. There were 3 infections identified in the cabotegravir group during the 1 year unblinded period, 2 without recent CAB injections, and 1 with no quantifiable CAB during the oral lead-in. So basically received the first injection at first positive visit and identified 28 days later. So if we look at the pregnancy outcomes, 132 confirmed pregnancies over 6,400 person years, and the pregnancy incident rate was 3.2 in the unblinded versus 1.3 in the blinded period. And what this tells us is that once women understood that what they were on, they weren't on a blinded therapy, they felt more confident. And you can see they were sort of less concerned about a pregnancy. And you can see that long-acting cabotegravir, there were 63 pregnancies, and FTC TDF 69 pregnancies, so very similar numbers. And both of them occurred more in the unblinded phase. So in terms of live births, these were similar. Pregnancy losses and congenital abnormalities, there was no differences in these. So the pregnancy outcomes are consistent with those expected in this population. In terms of take-home points for prevention, doxycycline was found to be safe and effective when taken as post-exposure prophylaxis to prevent STIs in people with HIV and those receiving PrEP. At 12 months, 6-month PrEP dispensing plus interim HST was found to be non-inferior to standard of care PrEP dispensing with significantly higher adherence in single women. And of women surveyed in Namibia, the majority preferred long-acting injectable PrEP for its effectiveness, dosing schedule, and discretion. Data from the TGW and the HPTN 083 study suggest that gender-affirming hormone therapy does not affect the pharmacokinetics of long-acting cabotegravir in transgender women. In the 1 year since unblinding, there have been 3 additional infections, none of which occurred with on-time dosing. So I'm going to move from there onto oral therapies. And the first study I'm going to cover is the bictegravir FTC and TAF versus dolutegravir FTC TDF for HIV and Hep B. So this was really, really interesting. So a hepatitis B and HIV cohort, both of whom on first-line therapy, so both naive to treatment. And this was a randomized placebo-controlled phase 3 study. And people had to have HIV greater than 500 copies and HBV greater than 2,000 copies. And they were randomized, as I've said, blinded to receive either bictegravir FTC and TAF or dolutegravir FTC and TDF. So you can see co-primary endpoints were for HIV and Hep B undetectable, HBV undetectable. So if we look at baseline characteristics, you can see these are very young people around 30 years of age. Very few were women. And you can see that the HIV log was 4.7 and the BDNA log was 8. And you can see the majority of people were Hep E antigen positive with raised ALTs. So on the right, what you see is the virological outcomes, firstly for HIV, and you can see that there was non-inferiority between the combinations there. And when you look at the second panel at the bottom, what you see is that bictegravir FTC and TAF was superior to dolutegravir FTC and TDF in terms of the primary endpoint, the co-primary endpoint of getting the HBV DNA undetectable. So that's a very, very important finding. In terms of other week 8, 48 outcomes, efficacy outcomes, ALT normalization didn't reach statistical significance, but there was a numerical trend towards improvement. In terms of resistance, You can see that there was one person on dolutegravir FTC TDF who developed resistance mutations, but nobody on the bictegravir arm. In terms of loss of hepatitis B S antigen, you can see that there was a significant difference here in favor of bictegravir FTC and TAF. And when it comes to seroconversion, you can see that there was a favorable outcome for hepatitis B E antigen seroconversion. So that was a really, really good outcome. So statistically significant differences here and numerically significant differences throughout. So if you look at the simple study at week 144, switching to dolutegravir plus FTC versus continued 3-drug therapy in patients with virological suppression, we're now looking at 3-year data in people who switched to dolutegravir FTC, and there were differences in how the monitoring was done. So what we see at 3 years, there was that dolutegravir FTC was non-inferior to continuing therapy, and the majority of people had switched away from integrase inhibitors, with 25% from NNRTIs and 6% from PIs. And you can see the non-inferiority very clearly here. And in terms of weight gain, they also looked at the weight gain. What you see in the solid lines is male participants, and in the dashed line were female participants. And what you see is over 144 weeks, men gained an average of 2.3 kilograms and women 2.6 kilograms, with no significant differences between the study treatments, and no significant differences in adverse events or quality of life between the treatment arms. In terms of the take-home points for the oral therapies, in the Alliance study of people co-infected with HIV, HBV, there was no difference in HIV RNA suppression between bictegravir FTC and TAF and dolutegravir FTC TDF, but bictegravir FTC and TAF resulted in significantly more participants achieving HBV DNA suppression at week 48. In the simple study, switching to D2G FTC was non-inferior to continuing 3-drug therapy, with no significant differences in weight gain at week 144. So the next thing I'm going to talk about was long-acting therapies. Now, there were a couple of studies presented at this meeting regarding long-acting therapies, and I'm going to start with the CARLOS study. So the CARLOS study is the German real-world study with implementation study of long-acting cabotegravir piperine, and patients and HCP perspectives is the first thing that we're going to be hearing on switching from daily oral therapy to long-acting cabotegravir piperine. So it's a non-interventional cohort in Germany, and 236 people with HIV was switched from daily antiretrovirals to cabotegravir piperine 2 monthly between May and December 2021. And what read out at this meeting was the perspectives of people with HIV and the healthcare professionals through surveys which were conducted at baseline. So firstly, on the left, we're going to look at patient-reported challenges with daily HIV treatment. And you can see the first challenge was that routine medication was inconvenient. The second thing was that they felt they had to hide the medications from others. Thirdly, the medications reminded them of their HIV status. And fourthly, problems remembering to take daily therapy. But actually, I think that these two bottom ones about being reminded and remembering are quite low, and hiding medications is also quite low. It's only about 30%. So what were the most common patient-reported concerns about long-acting cabotegravir piperine? So from the healthcare provider, so essentially the first thing that they were worried about was pain or soreness from the injection, impact on HIV RNA and CD4 counts, adverse events from the injection, scheduling travel or holiday, or no worries about the injection. So actually a third of people had no worries about the injection, which I think is quite impressive. But the biggest worry from people was actually pain and soreness, and then of course an impact on the viral load and CD4 count. Scheduling holidays was less of a concern. So in terms of perspectives on switching from daily oral treatment to long-acting treatment, healthcare providers noted that the main wish from their perspective, in terms of the main reason that they switched people was because of the wish of the patient. That was So that was their main motivation. So the people with HIV, if we look on the left, their reason for switching, they had a lot of different reasons. And the key reason was they were interested in an option that's more convenient. So it was mainly based on convenience and tired of taking treatments every day. Interestingly, the third one was that the healthcare professional recommends it, but the healthcare recommends it said that the main reason that they did it was because, the healthcare professional said that the patient wish was the most important thing to them. And then the patient said that the healthcare provider's wish was the third most important thing to them. So if we look on the right, we see that the healthcare professional perspective on PWH, the suitability was primarily people who are tired of taking pills every day, people who feel stigmatized. So they are prioritizing people who are stigmatized, and people who have anxiety over missing doses, and people with concerns about their status disclosure. So that was their fourth most priority. Concerningly to me, the fifth most important priority was being a male person with HIV. So they clearly felt that it was easier to give this drug to men. So in terms of the carousel study, this is a very large European implementation study for long-acting cabotegravir or pivirine going on in Europe. And there are around 430 participants for people who are stably suppressed, and they received an oral lead-in, and then they moved on to long-acting cabotegravir or pivirine. And what's important about this study in terms of this data is that we are seeing the primary endpoint. We're seeing the efficacy endpoint for this trial. So 87% had viral loads less than 50 by FDA snapshot. And what that amounted to was 0.7% with viral loads greater than 50. So this is a very important finding once again, because we're now seeing outcomes outside of the phase 3 trials for cabotegravir or pivirine. And what we've also seen is that the resistance and the efficacy figures are very similar to the clinical trials, in fact, slightly better. So what we see here is that there were two people who developed resistance. The one was a person who experienced confirmed virological failure. And the second was someone who was being suspected of having virological failure. And you can see the viral load at failure. And you can see that there were baseline and rilpivirine mutations in the first participant. And then in the second participant, you can see that there were no baseline rilpivirine mutations. So interesting finding, very similar to the clinical trials, in fact, slightly better, but certainly not worse. And I think it's interesting because it's important to remember that these findings occurred while COVID was in full swing. The participants many of them were enrolled and continued during COVID. So that this is I was very reassured to see these findings. In terms of the safety summary and injection site reactions, what we see here is that very similar to earlier trials, you do see reported adverse events, but they're rarely grade 3 and they rarely lead to withdrawal. Injection site reactions, once again, in large proportions of people, 86% of people, 98% mild or moderate, which also fits with the trials. The median duration of the injection site reaction fits with the trials. It's 3 days, and 82% resolve within 7 days. And this is very, very similar to what we have seen. So people withdrawing for injection site reasons, there was 25 people, and that's 6%. Now that is slightly higher than we normally see. We normally see about sort of 2 to 3%, 1 to 3%. So in terms of lenacapavir resistance from Capella and Calibrate studies, we're now seeing this poster, which basically combines the resistance from Capella and from the Calibrate study. And what it shows you on the left is the Capella study, which is the highly treatment experienced study. And what you see in terms of the primary endpoint was that 83% achieved viral loads less than 50 by week 52 in the randomized cohort. But you'll remember that there was a randomized cohort and then there was a non-randomized cohort. And the non-randomized cohort was for people that didn't get into the randomized cohort, but were still allowed to go on to receive lenacapavir. So they didn't meet the eligibility criteria. So if we look at what we are seeing in terms of the pattern here, we are seeing majority of the resistance occurring at week 4, with only one occurring at week 26. And if you look at the number of fully active agents, you can see that at least 3 of them had no fully active agents. These would have been the non-randomized cohort. And in terms of reason for monotherapy, the reason for lenacapavir monotherapy was the lack of adherence to the optimized backbone based on plasma concentrations. And then obviously in some people, there was no fully active antiretrovirals in the optimized backbone. So essentially the take-home message is that people who didn't do well in the highly treatment experienced study either didn't have any active antiretrovirals, so were on monotherapy, or they didn't take the optimized backbone, which was of course oral. So they were not taking 2 injectable agents; they were taking 1 injectable agent plus oral therapy, and they had difficulties with the oral therapy. So that's what that resistance analysis is showing. On the right is the Calibrate study, and this is about looking at first-line therapy. And what you see is that 90% and 85% achieved viral loads less than 50, but there were resistance mutations that emerged in 2 out of 157 people. And the first participant, the PK was on target for lenacapavir, and there was a suggestion of poor adherence to FDC and TAF because resistance developed. And then for the second participant, there was poor adherence by pill counts in terms of the oral therapy. So in all cases, it's related to lack of other agents and not taking the oral therapy. So the next thing I wanted to talk about was the injection site reactions in Capella and Calibrate, because we haven't actually seen an analysis of injection site reactions. So we're getting used to what that means in terms of cabotegravir pivirine, but what does it mean here? So the first set of tables is basically set of histograms is the incidence and severity of injection site reactions related to lenacapavir. So what you see is that no ISR is in blue, and this goes up. So the first injection, which is exactly like what we see with cabotegravir pivirine, is the worst, and then after that, the reports start to go down, and we've seen that in both studies. What about the duration of these events? So if you have a swelling, that tends to go within sort of generally within 4 days and sort of a month. If you have erythema, redness, it goes very quickly. It goes with sort of minimum of 2, maximum of 11 days. Pain, again, very quickly. Nodules tend to last months, weeks to months, and in duration. So there were 4 total discontinuations due to injection site reactions, 1 in the Capella study and 3 in the Calibrate study. All were grade 1. And the histopathology of the injection site reactions points to a foreign body reaction. So that's some interesting new information. In terms of the take-home messages, in the Carlos study, the most common reasons for switching were convenience and fatigue. In the Carousel, it was found to be effective. ISRs reported by 86% leading to discontinuation, and lenacapavir resistance occurring in Capella and Calibrate related to poor adherence or limited options, and ISRs related to lenacapavir occurring in Capella and Calibrate, mostly mild and rarely leading to discontinuation. Now, the City of Hope patient was possibly less interesting to me and then to some others. Basically, it's a 4th person with a long-term remission. Also, the only difference really is that it's a 63-year-old white person, so older than the others, diagnosed since 1988, so diagnosed a very long time, undetectable for many years. Once again, received the CCR5 Delta 32 donor for leukemia. And it was a wild type homozygous 8 CCR5 receptor, and received chemotherapy. And as you can see, has been undetectable now, has been negative as far as we can see for a very long time, 42 months. So impressive, response. Then the last thing I wanted to cover was COVID-19. So this is a study based on the WHO online platform of HCP submitted electronic reports of hospitalizations. And the majority of the people, around 97% came from Africa, from South Africa mainly. And 8% of these people, in terms of hospitalized COVID, were people with HIV. We're looking at the people with HIV by multivariable regression to determine the risk of 21-day stay in hospital mortality. What you see is that people with HIV had greater than one underlying condition versus without, and that was statistically significant. And that 52 had 1 to 2 underlying conditions, and 7% had more than 3. So there you can see the risk factors for in-hospital mortality, which obviously include age, CD4 count, the viral load, chronic kidney disease, diabetes, and hypertension. In terms of the risk of in-hospital mortality by HIV factors and differential impact by COVID variant on mortality, the first thing to say is that you pretty much double your risk if you have HIV, if you're living with HIV. This is regardless of your CD4 count and viral load, but if it's low, it's worse. And if you look at the effect of Delta versus Omicron, what you can see is that for Delta, the outcomes were very similar in terms of mortality. For Omicron, they've gone down for people without HIV, but for people with HIV, they are statistically significantly different from those without HIV, and they haven't gone down that much. So that's an important finding. But the analysis didn't account for vaccination status, which is very important, particularly in countries with very little access to vaccines. So with little ado, I'm going to open up to questions if there are any. And I'm just trying to see if I can actually see anything. No, these find modified questions.
Dr. Orkin, I'll ask you a question while we wait for some to come in. Can you speak to the Alliance study and what your thoughts are on why there may have been a difference there in TAF versus TDF and how that will affect your practice, if at all, at this point?
Well, I guess it's about higher intracellular levels of tenofovir, and I think I guess that might be, an important difference, the sort of lymphatic levels versus sort of cellular levels. And I think that's an interesting, in the lymphocyte versus, in the cell. So I think it's an interesting question. It's hard to know. I mean, the only difference that you can say really is the sort of the different actual concentration of the tenofovir molecule. So I think that would have to be, in my head, the biggest potential difference. And I think it would just really, I think this is really a discrimination, and this would push me towards using TAF rather than TDF in hepatitis B and using bictegravir, FTC, and TAF, because you don't know. It worked, and I would use it exactly as that.
Okay, great. And were there any other studies at the conference that were particularly interesting to you that we didn't have a chance to talk about today?
I guess moving to long-acting therapy, I guess one could talk about the SOLAR study. It was not covered. And the SOLAR study is a study again of bictegravir, FTC, and TAF against long-acting cabotegravir or pivirine. And we saw the very first reading of this trial, which was to see what healthcare providers thought about using the oral lead-in. And basically, it's really dependent on a number of things. If they were comfortable with the side effect profile, they were happy to dispense with the oral lead-in. And one of the other factors is people HCPs who had been in the previous trials using the oral lead-in didn't want to get rid of it. But there were quite interesting regional differences from country to country on who decided to continue with the oral lead-in and who dispensed with it, because obviously now you don't have to use the oral lead-in, and it was a choice. So I think that was an interesting finding, that there were such regional differences in what people would do. And I think, there was so much data that it's actually really quite hard to put my finger on anything. There was a very interesting plenary on sort of disparities in PrEP by Patrick Sullivan, and I really suggest that you try and watch that on demand. It was a very, very interesting presentation, and I think we're going to cover it in the clinical slide set.
Yes, thank you for that reminder. For those in the audience, there will be a downloadable slide set posted that will be an expanded slide set. So it will have some additional studies that were not covered in the webinar today, as well as what was covered today. We have one last question. Were you surprised by the lack of weight gain difference in the simple HIV study between the 3-drug ART and dolutegravir FTC?
Not particularly. I mean, I think we don't know what the NRTI was. It just says 2 NRTIs and integrase inhibitors. So they were mainly 70% of them were on integrase inhibitors. So you would expect more of a difference if people switched to integrase inhibitors and away from TDF. But we don't know what the 2 NRTIs were. So I think with so little knowledge, it's hard to know. I wouldn't have sort of expected or not expected a difference.
Thank you very much to Dr. Orkin. And thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.